Let's we start after the break. I think Dr. Hemans is on. Our next speaker
in April
is
of 2012, he was awarded the FCPS and
Dr.
CPS
Hemans
of Pakistan.
Prabhakar, Professor
In 2012
Neuroanesthesiology and
August,
Critical Care,
he
AIMS,
was
New
awarded
Delhi.
the FSLCS.
Sir is going to talk
That's the
about
Sri
the
Lanka
basic
College of
principles of
Surgeons
neurocritical care nursing.
Fellowship.
And Sir is the Limca book
2019
recorder as well as
He also
published a
received
lot
the
of
FRCP,
books.
the Royal College of
And
Physicians.
always we are having that
2020,
neuroanesthesiology
he became
books
a fellow of the American
in
College of
multiple
Surgeons.
times. So thank you, sir, for that. And sir, you can continue now.
He has.
Thank you, Anjali, for the invitation. And should I share the screen now? Without any further delay, it's already 7:01. And once again, thank you to all the organizers for inviting me to talk about on the basic principles of neurocritical care. I think this is something which all the nursing staff, they have been doing it practically day in and out. Every day they're doing it. But this talk of mine would simply be recapitulating everything that they have been doing and with some key points that they need to keep in mind. Now, one thing we have to admit, the patients who are admitted in the neuro ICU, they, along with their relatives, they are a very vulnerable group and they are practically at the mercy of all the personnel in the ICU. Now, because of the patient's neurologic state, they are unconscious, at times they are sedated. It is rarely possible to communicate through them via normal means. And so the nurses, it is the nursing staff who have to take all the decision as to how to give the best possible care. And how are they going to do it? Based on the clinical parameters, the clinical status of the patient, along with what all things they are monitoring. So now if we look at the responsibilities of nursing staff in the neuro ICUs, so here are some of them. Firstly, the neurophysiological interventions. They need to monitor the patient, the general status of the patient, the various monitors that have been attached, they have to take care of that. Patients are on ventilator, they have to manage the ventilator settings and all kinds of monitoring that is required because it is the nursing staff who is present throughout the day with these patients and not we physicians, which is a fact. And we have to admit that. Now, nursing staff, it becomes their responsibility that there is no injury to the patient and to prevent any kind of injury. Now, how can these injuries occur? At the time of positioning of the patient, then you need to take care of the hygiene of the patient. And then you have to prevent patients, at times they become violent and we are all well aware of it. So we have to take care of that so that the patient doesn't fall. So indirectly, you're preventing any injury to the patient. Now, another very important point is maintaining therapeutic milieu. Now, this I'll be discussing in one of the slides later on. And this means that any kind of stimuli to these patients has to be limited. Now, this stimuli could be in the form of light, noise, the visitors. So all these things have to be limited. And then the psychological interventions. Again, it becomes part of the nursing staff. It's not just the doctors who has to consult with the relatives of the patient, but it is important for the nursing staff also to effectively communicate with the relatives. Now, one way of to provide good education and improvement quality of patient care is to have a well-organized rounds, which we have in our ICUs also. I've often seen the senior most sisters taking round with the junior staff, and which is very, very important because they have to teach the junior staff and what all things you need to take care of while you need to discuss during the rounds. That is the risk of infection, how to prevent fall of these patients, how to prevent the pressure ulcers, by changing the position and taking proper care of the skin. Along with that, pain management and psychological factors like delirium, hallucinations, all these things have to be understood while they are taking the rounds. So let's begin with the hygienic intervention. Now, washing a patient is also a way to show concern for them. So if somebody is cleaning you, washing you, indirectly it is your attention or the fact that you are caring for the patient, and only then you're doing all that. And while performing the hygiene intervention, it is the nurse who gets the opportunity to assess the skin of the patient, that there is no particular ulceration or any kind of injury. So giving daily baths is very important. And it is also important to time the hygienic interventions so that it doesn't disturb the sleep of the patients, right? And I'm sure you will understand, if a patient is sedated or he's asleep at maybe very early in the morning, it's not the time to wake up at 4 o'clock and then start cleaning. No, so that also we need to keep in mind. And then it is important that because they are cleaning, they are exposing the patients, it is important that they understand that it is very likely that they would become hypothermic. So that also needs to be kept in mind. And I'm sure everybody knows how washing is done by with the soap, water, dry it nicely, put moisturizing cream, and then comb the hair well and prevent all, if it is a male patient, shaving of the patient and all these things which you have been doing. Oral care, again, very important. It decreases the risk of ventilator-associated pneumonias. A good hygiene of the mouth, that will prevent that. And it has been shown that oral care has no effect of ICP among the TBI patients. So it doesn't mean if you're cleaning the teeth, it will raise the ICP. So that you need to keep in mind. And there is a Cochrane review which suggests that chlorhexidine mouthwash, it reduces the risk of ventilator-associated pneumonia. And there's strong evidence that using a toothbrush as a complement to chlorhexidine mouthwash reduces the risk of VAP, that is the ventilator-associated pneumonia. So there's no evidence for that. And the best way to reduce dental plaque is by using a small, soft toothbrush and a non-foaming toothpaste. Chlorhexidine has been recommended and found to be very effective. And the saliva, we should also remember this, that saliva also gives some support and it prevents plaque and microorganisms in the mouth. And for that reason, it is important to prevent any xerostomia or dryness of the mouth. Eye care, again, a very important part of nursing care in the ICUs, and to prevent any kind of ophthalmic injuries. Now, if just wanted to have a word about the ventilator eye. So in intensive care patients, they often suffer capillary leakages in the eye, which causes conjunctival edema. So that's known as the ventilator eye, and that has to be prevented by putting lubricants and saline-soaked gauze by that. Now, skin care is important, as I said earlier, just to prevent ulcers and also any kind of contact dermatitis. Now, how do these skin ulcers develop? Mainly because of the impaired circulation, underweight or immobility, malnutrition, long surgeries, prolonged mechanical ventilation. These things cause skin ulcers. So repositioning should be performed every 3 hours or 4 hours in order to prevent ulcer formation. Now, surgery, wound management. So although we have junior doctors who are doing the dressing, but then at times it becomes important for the nursing staff to know how to keep the wound clean. And so it is important to see the local signs of the wound infection, such as there could be pain or there could be oozing, there could be local erythema or swelling. And all these things will delay the wound healing. So that every nurse needs to ensure that no such thing has developed. And if possible, the dressing from the operation room should remain intact and unchanged for at least 48 hours. You don't need to change repeatedly, but change only if the gauze gets soaked or it has become dislodged. Now, airway, although they say it's the part of the role of the anesthetist to handle the airway, but then yes, the nursing staff definitely plays an important role along with the anesthetist. And it's important to perform suctioning because tubes can get blocked. And how do I know when to do suctioning? So whenever you hear a visible or audible secretion during the ventilation or coarse or absent respiratory sounds, patient may be desaturating or there may be increased efforts of respiration. The patient is fighting the ventilator. try to think on the lines of the airway, that it is possible that the patient is having secretions. And we have stethoscopes almost on every bed. So it's important that the nursing staff also develop this habit to listen to the chest, auscultate the chest, and see if there are secretions. And the catheter, it should, when you're performing suctioning, it should not be there for a long time, not more than 15 seconds, or your patient could start desaturating. Now, this is what I was talking about to maintain the therapeutic milieu. And interestingly, it was Florence Nightingale who mentioned and talked about it in her notebook, the notes on nursing. What is it and what it is not? And here she talks about how these things can, any kind of disturbance or stimuli, it will impair the recovery of the patient. Again, we will admit, and to be very honest, even I have experienced, whenever we shift the patient, there's a lot of noise, a lot of chaos in the ICU, and the lights are on, and they're shifting, and there's banging of the door, and people are, in a higher voice, they're trying to call somebody, the attendants, and things like that. So all that we need to keep in mind so maintaining a therapeutic milieu is of extreme importance, and circadian rhythm, the difference between the day and the night, that has to be maintained so that the patient knows, even if it is an unconscious patient, we must consider it, that the patient should be aware that whether it's the daytime or the nighttime. So all these things, the internal therapeutic milieu has to be maintained. Sleep, again, as I said, in neuro ICU, the environment is such that it exposes the patients to light, noise, the treatment and the nursing activity, the doctor's rounds. So it's not always the nurses who are disturbing the patients, but at times the doctors are coming at odd hours and taking rounds. All these things will affect the sleep of the patient. And that indirectly results in what? Anxiety, pain, discomfort, and all the loss of circadian rhythm, which actually affects the recovery of the patients. And then there are psychological interventions. Now, it is very important because, again, I'm repeating, it is the nursing staff who first comes in contact with the relatives of the patients. And so it is the nurse who has to give the next of the kin or the relatives the experience of being seen, confirmed, and accepted as they are, which means we have to accept how the patient is, what is the situation, or how serious the patient is. But then it is our duty how we communicate it to the relatives. So the information has to be repeated several times in different ways, but it has to be factual. And try to give them some hope. Yes, your patient will become all right. Pray to God, have faith. All these kind of words and communications are important when you're talking to the relatives. And we don't just say, no, your patient is going to die. He's very serious. No, that's not the way of communication. So the relatives have to be, they should feel that, no, yes, the nursing staff is taking care, the hospital is taking care of my relative, and my relative is serious, yes, but they are giving us a hope that he'll be all right, and those kind of things. And then, although at times this becomes very theoretical, that you have to offer help to the relatives also, you give them financially, you can help them. If they are in need of food or something, a resting place, you can provide that. So at individual level, it becomes difficult. But yes, as a hospital, we know we have proper places where the relatives can stay. We have NGOs and social workers who can help them and support them in whatever their requirements are. So all these things we need to keep in mind. So it's not just the patient who's in the ICU, but also the relatives and the psychological support that we give to them. So you have to be extremely kind and concerned about the patient. So for us, we daily, day in and day out, we are seeing these kind of patients. So probably we become a little immune to it. But then for the relatives, it's their first experience maybe that they're coming to a hospital, and that too when the relative is very serious. So considering all these factors, you need to keep in mind, along with the general care of the patient, the skin care, the oral care, the eye care, the psychological care of the patient, it is also important that you need to keep the relatives in mind also. So a very brief overview of what the nursing staff has to do in terms of their commitment towards the patients. So to conclude, I can say that neurointensive care patients, they are vulnerable, and it is a multidisciplinary care team, which is important to handle the complex situation. So it's no one department or specialty can take the responsibility and say, no, this is my patient and this is my responsibility. It's a teamwork. So the nursing staff or the technical staff is as much responsible for the patient as are the doctors and the paramedics. So they all have their important role to play. And with a proper balance between the nursing interventions and preventing the secondary insults, and patients can have a potential to recover from severe injuries with minimum of complications. So the more you care for the patients, keeping in mind these little small things, you can have a very good outcome of these patients. So we know that neurologic patients have a morbidity and mortalities. Of course, you do have mortality in any case, but neurologic patients tend to become morbid later on, and that too in a large number. So it becomes very important that how you take care of the general care. That by care I mean the general care, that is the nursing care, and how well we take care of these patients will only result in good patient outcome. Thank you so much.
Thank you, sir. Thank you so much. Thanks a lot for your elaborate and excellent lecture. And of course, I would like to give a special thanks that nurses are very important along with
Yes.
neuro anesthetist.
Yes,
So,
yes,
of course, it's
definitely.
true.
Yeah.
Yes. And we have to learn the humble and kindness from you, sir. I don't know, only you can maintain.
That is very true that you're pointing out. And I would I would not be exaggerating if I say that it is
Yes.
the nursing staff who is running the ICU. Not
Yes.
just the
Of
neuro
course.
ICU, it is
Yes.
any ICU if you visit, it is the nursing staff who are actually running the ICU. Because
Yes, of
you are
course.
day in and out, right? 24 hours round the clock, one nursing person is standing by the patient side. And it is
Yes.
not the doctors. So it is
Okay.
always because, and you're the first, contact, I would say, or the communicating link between the doctor and the patient who's in the ICU. So it becomes very important. And now I understand because in our setup, we have a lot of patients. There's too many, relatives, they're coming up, they have a lot of queries, a lot of concerns. But then it's very, very important that we maintain our patients. We should not lose our patience. That's one dictum which I always say. No matter
Yes.
what happens, no matter how
Of course.
rough the relative becomes, if the relative is becoming violent or very rude or rough, just ignore that and maintain your calm. That will solve a lot of problems. That will solve a lot of problems. Practically, I know it is a very difficult task, but it is not impossible. I have also, as a resident, I have faced relatives who were very vocal. But I used
Okay.
to just at the bedside in the wards, I remember I used to just stand, listen to them for a long time. Go on, let them vent out, let them,
Okay.
their frustration, let them talk about it. And in the end, give your comment. See, this is the practical issue.
Of
This is the
course.
problem.
And
So I
listening
think
is
that's
important
very,
than speaking, isn't it, sir?
yes. Listening is
Okay.
definitely important because that calms the person in front of you also because he also feels there is one person standing who's listening to them.
Yeah,
So
of
that
course.
gives a lot of confidence in that person that yes, this person will listen to me maybe if I talk to him. So I think that we need to incorporate in ourselves the patience.
Yes.
That is.
Okay, sir. Thank you so much.
Thank you. It was a pleasure.
And for the acceptance with your busy schedule, you make the time for us. So for that,
No,
special
it's
thanks
always
from
a
our
pleasure.
side.
It's always a pleasure. Thank you
Okay,
so much.
sir. Thank you.
Thank you.
And let me move on to the next speaker. Mm, Next speaker is Mr. Vensing Prince, nursing officer, neurosurgery ward, AIMS, New Delhi. He will talk about nursing care of patients with EVD. Prince, you can.
Yes, thank you, Sister Anjali. Am I audible? A very good evening. I welcome you all for this session, and I especially thank the organizers for providing me this opportunity, and also the previous speakers who have done a wonderful talk about the important aspects in neuronursing. So in this session, I'm going to talk about care of patients with
Please on your slideshow.
extraventricular drain.
Slideshow mode, sir, please.
Yes. Yes, I have got it. I have shared. Is it clear now? Is it visible?
Yes, sir.
Yes.
That's okay. Thank you. Thank you. So in this session, I'm going to talk about taking care of patients with extraventricular drainage. As a neuro nurse, working with the neuro patients, we are more concerned about maintaining the patient's intracranial pressure within the range, because it is a big challenge for us. So we should take prompt actions, and we should practice certain skills so that we can easily assess whether the patient's intracranial pressure ICP is maintained within the range or not. So raised ICP is one of the most common problem, and it is a medical emergency. It has to be treated promptly. There are lots of causes for ICP. The most common in our practices, hydrocephalus. Irrespective of the cause, acute hydrocephalus. What is it? Hydrocephalus is simply what we commonly call as water in the brain. When the normal CSF pathways get obstructed, or it has been in somewhere it get blocked, what happens? The ventricles, the water, the CSF secretion will stagnate, and it will bulge the ventricles, and it cause increased ICP. So in such situation, we will go for an intervention in such acute hydrocephalus situation. The short-term intervention, what we carried out is extraventricular drainage. It is an life-saving device which helps to relieve the excess CSF which is produced, thereby decreasing the intracranial pressure. So we will see it in detail. Okay. Well, as I told already, it is a life-saving device used in patients with hydrocephalus to relieve the elevated intracranial pressure. If the pathway of CSF got obstructed somewhere, so obviously it is going to rise the intracranial pressure. So this time I'm going just want to refresh you all with CSF circulation and its formation. You would have known very well about this, and I'm just going to give. I just want to sensitize with this information. Okay, so you all know that cranial vault contains 3 important components. Shortly we will call as BBC: brain cells, blood, and CSF. So you know that it is a rigid structure, and these components, the volume of these components should be maintained in an equal volume or in an equal level. So there is a famous hypothesis, Monroe-Kelly hypothesis. You would have studied. We would have studied in our graduation level. It is what it says: the volume of these 3 components should be maintained constantly. If increase or changes in any one of the component, any one of these component, will reciprocally decrease the either one or two components. Oh, you can see in this. You can see the normal brain over here. There will be a venous volume will be there, arterial volume, brain, and CSF. What happens if there is any injury to the cranial vault? If there is a pressure is increasing, what happens? You can see it in the second image. The venous volume as well as the arterial volume is little bit decreased. The area occupied by this blood vessels get decreased, and you can see the brain portion, it got edematous, and there is an increased intracranial pressure, and the CSF part is also get decreased. So it is a compensated edematous brain. The brain is compensating the pressure. So you can see such kind of alteration. Physiologically, the body is trying to coping up to maintain the pressure. So in case of hydrocephalus and uncompensated brain, you can see there will be an increased ICP and hydrocephalus, the brain volume, as well as the blood supplies, both the arterial and venous area get shrinked because of the increased pressure. Next, we will see about the CSF protection. As you know that the name itself, the words itself, CSF, C stands for clear, it is clear, and S for odorless, it's a smellless fluid, and F for fluid, it provides oxygen as well as nutrient to the CNS cells. Okay, it is produced by, you all know that choroid plexus, it is a network of tiny blood vessels with specialized ependymal cells. It is constantly produced and reabsorbed. CSF is constantly produced and it is reabsorbed. So you can say at an approximate of about 500 ml is produced per day. A healthy adult, if you see a healthy adult, you can see only 150 ml at any time in the circulation. On an average of 125 ml is present in the subarachnoid space and 25 ml in the ventricles of the brain. So this thing you have to keep it in mind, because when take care of the patients with such drains, you should know how much amount of the drain has to be drained in an hour and per day. So you should be the basic of this, and if you know the basic of these things, this amount, you can easily predict whether the patient is draining more or less. Okay. Next, circulation. As you all know that we have two lateral ventricles, third ventricle and fourth ventricle, and from the fourth ventricle, subarachnoid space, the CSF runs to the subarachnoid space. From the lateral ventricles, the foramen of Monro to the third ventricle, the CSF flows, and from the cerebral aqueduct through the cerebral aqueduct, third ventricle CSF comes to the fourth ventricle, and from the fourth ventricle, it will go to the subarachnoid space through the lateral aperture as well as median aperture to the subarachnoid space. So the flow from lateral ventricle to fourth ventricle, the CSF flow will go in an unique direction, in one-way direction. There is no any diverse direction, but in a single way. It's a one way. It flows from in a constant way. But when it reaches the subarachnoid space, the CSF will get moves in, go in various directions, and it is absorbed by the arachnoid villi, and it goes to the venous circulation. Okay, and the functions, you know that it cushions and supports the central nervous system, and it supplies the nutrient and as well as the metabolic waste from the CNS. So what? As I told already, I just mentioned this one, the direction of the CSF flow in the ventricles as well as in the subarachnoid space. It is eventually when it reaches the subarachnoid space, it is eventually absorbed by the subarachnoid villi. So the next one. So what are the indications for EBD? Why it is indicated? As I told already, the first and foremost thing is to treat the hydrocephalus. If the pressure is increasing, the CSF protection is more. To treat that in a short-term basis, we will go for this extraventricular drain, and to monitor the ICP, especially it is a gold standard to monitor the ICP, especially in subarachnoid hemorrhage and traumatic brain injury and intracranial hemorrhage patients. You can easily rule out the ICP by using extraventricular drain. And as well as in specific condition, what happened if the ventriculitis, if the patient is having inflammation in the meninges or in the ventricles, we can directly with the help of the drain circuits, we can administer medications. So we can directly treat the inflammations. So and in case of any obstruction, to divert, we can also divert the CSF from the blood-stained CSF from its regular pathway, because if blood-stained CSF reaches the subarachnoid space, what happens? This blood components will interrupt. It will block the arachnoid villi's primary function, and it will get trapped inside it, and thereby it increases the intracranial pressure as well as the ventricles enlargement will be there. So it is indicated for whom? So indications, we will see about the patients who are indicated for EBD drain. So following SAH, subarachnoid hemorrhage, and intraventricular hemorrhage. As I told already, the blood products, the blood components, what happens? It prevents the absorption of CSF. And the next one is tumors in or near the fourth ventricle. and as well as any infections or exudates from the meningitis or encephalitis. It will also, the exudates, the byproducts of that inflammations also obstruct the CSF pathway as well as its absorption. And especially in certain genetic disorders like acute stenosis and Dnacon syndrome and Arnold Chiari malformations, and there will be a stenosis, and the flow of this CSF will be interrupted and narrowed, and it get what happens, the CSF accumulation will be more, and thereby it increases the intracranial pressures. And moreover, tumors, especially in the choroid plexus or near to the ventricles, it will increase the secretion of CSF. There will be an increased CSF production. In that situation also, we will go with an extraventricular drain. Okay, so insertion. So it is a part done by the neurosurgeons, but even though as a nurse, the neurosurgeon nurse and neurological nurse, you should cover that where the exact insertion is made, and you can see. So the insertion is made at the Cocker's. There is a point called Cocker's point. This is the exact location where the insertion of EVD is done by the surgeons. Mostly it is inserted in the right lateral ventricle. Now in the anterior part of the lateral ventricles. So it is approached by the Cocker's point is approached by. So the right mid pupillary line, either in the right or left. I will tell it. I will describe it laterly. So the point is, from the mid pupillary line, you have to draw an imaginary line, and from the nasion, that is that metorpic sutures will be there. So when it reaches, there is a 3 centimeter from the nasion, that is the metorpic sutures, to the mid pupillary line. The Cocker's point will be there. So the surgeon will be inserting in the exact point. They will insert the catheter in that particular area. So why right hemisphere is mostly preferred in the sense is, usually the left side of the brain for right dominant people, the left side of the brain is more inactive, as well as our language production is the Broca's area is present in the left side of the brain, left cortex. So penetrating or inserting in that particular area will interrupt in the language production of the language, and the speaking ability of the may affect the speaking ability of the patient. So mostly the surgeons will go with the right lateral hemisphere. But in case if there is a tumor in the right lateral ventricles, or near the right ventricles, lateral ventricle, then the surgeon will go with the left. It's purely the decision of the surgeon. As per the condition of the patient, they will go with it. But most commonly, if there is an obstruction or blockage, right lateral hemisphere will be used. The next one. So while inserting the extraventricular drain, you should keep it in mind some points as a nurse, and when you are assisting in the emergency situation. So you should keep certain things in your point while you are assisting the surgeon, or while you're taking care of the patient. Okay, so it is highly invasive, and strict aseptic technique should be followed. There should not be any compromise in that. Okay, then you should keep it in mind that this EVD is a short-term solution for HCP, and if the problem doesn't resolve, usually what will they you have to go for placing cerebral shunt. If usually what will the time period for the EVD as per our ward protocol is only for 5 days, because only the 5 centimeter of the catheter will be inserted into the ventricles, and after once the 5th day is reached, if the hydrocephalus does not get resolved, we will go for a cerebral shunt. It is commonly placed by a twist drill craniotomy, as you all know that. And as I told you already, the Cocker's point is the landmark to access the anterior horn of the ventricle and drill to insert the catheter. So rarely left side is drilled, depends upon the surgeon discretion. So then you should know about the parts of EVD drain. The first one is there is a drain catheter will be there. So it will be tunneled. It will be tunneled a few centimeter before it reaching the ventricles. Okay. The next, there will be a three-way stopcock will be there, depending upon the equipment. It will differ. Ideally, it will be there. And next, there will be a scale, calibration scale with a positive and negative calibration, and there will be a drip chamber with calibration, as well as then there is a 3-way with level adjuster, as well as a transducer will be there to monitor the ICP. This 3-way will be used. And the next one is CSF collecting back. So the whole EBD the system consists of the CVD catheter and a calibration scale with a drip chamber and the transducer to monitor the ICP, the monitor, and a three-way and a collecting back. Okay, this is all about the. So what is the nursing responsibility? So you have to keep it in mind while taking care of the patient. Okay, so as I told already, as I said already, strict aseptic technique and a vigilant nursing care is highly recommended. So you should not compromise with this, and because it is it is directly related to the brain. Infections may lead to severe complication to the patient. So barrier techniques and aseptic technique should be properly carried out. So any disconnections or signs of deterioration must be reported immediately to the surgeon. So when you see a patient, when you take care of patients with the EBD, the first important thing you should do is you should keep a signboard that the patient is having EBD on the patient's head side. Okay. So the next thing is the patient head end should be elevated 30 degree as well. The head end as well as the trunk of the patient should be elevated 30 degree. So there will be a proper intracranial pressure will be maintained, as well as the cerebral perfusion pressure will be also be adequate, and the venous return will be also proper. So proper, as I said, proper hand washing and aseptic technique should be followed. Then what you have to, as a nurse, what you have to monitor. The first one is GCs of the patient. Especially every hour you should monitor the GCs of the patient if the patient is having an EBD, and especially the pupillary reaction of the patient. In case if there is an increased ICP, what happens? It reflects in the pupils of the patient. It will go with the fixed and dilated pupils. If the ICP is increasing gradually, means it starts with the unilateral eye and then slowly it comes to the bilateral eye, the second eye also. So bilaterally there will be a dilated pupils will be there if there is an increased pressure inside the cranial part. Okay. Next, you have to check the incision site for any oozing or leakage of CSF. Unless otherwise indicated, the dressing should not be changed. Okay. If it is soiled or the oozing is present, you can report to the surgeon, and then with the help of the surgeon will change the dressing. Unless otherwise indicated, it should not be changed. The entire integrity of the EVD system should be checked every 4th hour. So you have to check all the connections, the stopcocks, the transducer, and the collecting back, whether there is any leakage or any disconnection should be checked every 4 hours, and in the beginning of every shift and in the end of your shift. So in case of any disconnection, you should clamp the line that connects the patient to the system. So immediately, if there is a leakage or if there is a breach in the system, so immediately what you should supposed to do is you should clamp the or you should turn the stopcock that is connecting to the patient, and you should report the incident to the surgeon. Monitor the patient for early signs of raised ICP and infection. So when the patient is on the drain, you should monitor whether the patient's ICP is in normal range or not. So how do you know that you can assess the by certain signs? The Cushing triad, the patient will having increased widened pulse pressure will be there. Then there will be a bradycardia or bradypnea will be there. So this kind of signs will alarm you. There is changes in the ICP, and as well as infection. The first sign of infection, as you know, that there will be a rise temperature will be there, and respiration changes in the respiration will be also there. So this you have to monitor. Next, you have to monitor the CSF drainage, whether the drainage is adequate or not, and its color, whether it is blood stained, or sometimes during the procedure, what happens, the blood may enter it, and there will be a blood stained CSF drain will be there. And every subsequent day, you have to see whether the color of the fluid is changing or not. So repeat immediately. You have to, moreover, you have to check the amount of CSF that is draining. It is recommended that 5 ml per hour is recommended for the drainage. So 120 ml in a day. Okay. So if the amount exceeds greater than 20 ml per hour or 10 ml increasingly by every hour, so it should be reported immediately to the surgeon, because it means the CSF is draining too much. So the next one is you have to monitor the intracranial pressure on the beginning of every shift. As you know that the normal pressure is 0 to 15 mm of mercury, and greater than 15 is said to be rise ICP. So the next one is you have to maintain the cerebral perfusion pressure between 60 to 100 mmHg. So cerebral perfusion pressure indicates that the brain is getting adequate blood supply. So how will you get that? You will find the map minus intracranial pressure. Map, how will you find the map? It is systolic pressure minus 2 into diastolic pressure divided by 3. When you apply this formula, you will get the mean arterial pressure. So when minusing this score with ICP, you will get the cerebral pressure. So the next important thing is leveling. So why leveling is important is, if the leveling is not adequate, if you place the drip chamber higher than the prescribed level or in the near to the ventricles, if it's not horizontal to the ventricle, what will happen? The CS will not be flow adequately. If the level is too low from the ventricles, what happen? Excessive CS will be drained, and there will be a ventricular shrinkage may happen. So the level of the pressure transducer should be horizontal to the level of the ventricles. So the pressure transducer in the ICP monitoring should be with the level of the ventricle. So it is achieved by making the zero correction level line in the tragus of the patient to the external auditory meatus. So when the patient is lying down to the tragus, this area, the drip chamber should be placed in this level only. Okay.
Friends,
So
time
the
up.
next, okay.
Quickly finish up.
The next one is, okay. The next one is, if the patient is at lying position, as I told already, if it is a sleeping position, lying position, it is the sideline position, it should be level at the mid-sagittal line, but that is between the eyebrows. So every time the patient moves, the system should be re-leveled. So while during transportation, what you should do is it should be clamped, and once if the patient is shifted for CT or MRI, it should be clamped, and once the patient comes up from the CT or MRI, it should be released. So, and sampling also, while you are sampling, it should be done without aspiration, or it should be done in the recommended port only, or otherwise there will be an aspiration, there will be a risk of aspirating brain parenchyma. So then check the patient for any complication and report the surgeon immediately, and you should as a nurse, you should document every single action you carried out on the patient. Okay, so and the complications, as you know that there's a chance of infection, and there is an accidental removal or blockage or leakage may happen, and even the procedure itself cause hemorrhage. So you should try to avoid that one. And the epidural hematoma, because when you make a drill, what will happen? There is a chance of hematoma formation in the epidural layer. So this is all about the EVD care. So hope you understand. Do you have any queries? So thank you so much.
Thank you, friends.
Thank you.
You did a great job, and with your, I know you were very busy in your ward, even though you made a time to present here, and it was a wonderful presentation. Hope that everyone understood about the EBD care, and let's move on to the next speaker.
Thank you, Sister Adeli.
So the next speaker is from our department itself, Ms. Rekha Pradhan, Senior Nursing Officer, Neurosurgical Operation Theatre, AIMS, New Delhi. Ma'am will present on existing pandemic challenges in neurosurgical operation theatre. I think it's a very hot topic for this conference. Ma'am Rekha, please sit down.
Thank you, Anjali.
Okay.
Can you hear me, Anjali?
Yes. Didi, you can carry it.
Okay. Good evening, everyone. My topic is Operation Theatre Management Challenges during COVID-19 pandemic. Actually, this is my 10-month experience during COVID pandemic time, which I am going to share with you all. That's it. Although everybody was quite aware about the coronavirus, but still lots of misconception and along with anxiety was there among the staff. coronavirus disease has created a tremendous pressure over healthcare system globally. During COVID-19 pandemic, has been many changes to practices. The operation room environment is a different place. The general dynamic in operating room is less relaxed due to multitude of challenges. Transforming operating suites into COVID-19 safe workplace overnight has been a challenge. Effective implementation of standard protocols pertaining to COVID-19 is a big challenge for hospital within the existing limitation of time and resources. So we have faced many challenges like training to the trained and non-trained staffs, coordination among different departments, creating proper donning and doffing area in existing setup, patient receiving in operation theater, health issues related to the use of PPE, N-95 mask, face shield, etc., and timely takeaway of COVID waste from the operation room. Then the hazards related to the repeated fumigation and disinfection, and death of coronavirus patient in operating room if happen. Placement of assignments also is a big challenge for us. So training to the trained and non-trained staff persons. See, there is lots of misconception I already told. People have a knowledge about the coronavirus disease, but they are more anxious about what will, how dangerous it is and how it will affect on us, our family, etc. And daily the new guidelines are coming, and it was really difficult to interpret those guidelines. Then there is a sudden change in the situation. General health practice has been changed suddenly. So people also have less acceptance towards to adopt this situation. And to teach all the person at a one time is also a great challenge because all the time, all the staffs are not present at that time. So how we manage that situation? We create the teaching session in the morning for half an hour or 20 minutes. So that time we discuss the guidelines and demonstrate how to don and doff the PPE properly. Then we make them understand that how the dangerous the disease is, and we should maintain the guidelines what the government has given to us. Then we have lots of staffs like nursing, including nursing, teaching, technical staffs are there, hospital attendants are there, sanitary personals are there. Those have not much knowledge about the disease, but they know that disease is some disease is happening, and but how severe it is, they don't have much idea about that disease. So we have given the teaching to each person separately, like hospital attendants and sanitation personnel, that they have to keep the COVID waste separately from the normal waste, and hospital attendants also, that how they have to manage inside the OT during helping others and during disinfecting the OT or fumigation of the OT, like that. Then coordination among the different departments was also a big challenge, because though all the departments have different role, but during pandemic, joint effort of all the departments was required for smooth functioning. And all the departments like hospital administration, procure departments for PPE demand and supply, general store department, like excessive use was there for the shoe cover, disinfecting solution, for fumigation also. So, and the air conditioned personal department also has a great job, because we have to maintain the pressure from positive to the negative pressure in during COVID pandemic. Then sanitation department also, how to segregate the waste, then collection of the waste, and where we have to store the waste until it has been taken from the OR, then disposal of the waste from the OT. These all are the problems which were there, and for all of this we need the coordination of all the departments. So what we have done then, we assignment already, not we have done, our hospital administration have assigned different jobs to the designated personnel, such as special infection control committee, nodal officers. They have also subordinate people to whom they have assigned the jobs to do all the functions for the smooth functioning. Then we initially there was a problem for the supply of PP, so we tell the staff for the judicial use of PP, and we allow minimal person inside of the OT so that we can maintain the provision of the supplies. Then we maintain OT pressure from the positive to the negative with the collaboration of the AC department. And for the sanitation department, we talk with them, and they have tell us that 24/7 service will be provided, and they have also issued the helpline numbers also in case it is an emergency. The other challenge was creating donning and doffing area in existing setup. This was a big challenge because our infrastructure was not like that, and we need a designated operation room for the COVID cases. Though in our operation theater, all the positive cases were not coming. That in AIMS, trauma center was designated for the positive cases, and but in here all the trauma emergencies were coming. So we need a designated specific operating room for the COVID cases also. And ideally, we know that the separate operating room should be there with isolated ventilation system, and it has to be negative pressure, and only essential things should be there. No unnecessary article should be there. And the other thing was the limited hospital layout. We can't do any new construction just immediately. So we have to manage the space what we have. And for that, we sacrifice operating room for the doffing area because it is near to the existing OT which we are operating. So one of the OT we prepared for the doffing area, because for doffing we need a wide space, because during doffing there is a chance of getting the infection was maximum. And the other thing, for donning, we compromise with the space, and we created the donning area next to the scrub station, and surrounding was covered by using the screens. So because in donning area, less chance, there is no chance of infection, only we have to need a clean space to don the attire. So we use the next to the scrubbing station. And shower facility after doffing was also a big challenge. Ideally, it should be near to the exit point of the doffing area. But in existing setup, it was not possible. So what we have done, we choose the operation theater for the COVID cases, suspected COVID cases, near to the changing room, so that the person can go after doffing just to the changing room and had a shower and can change the scrub suit. Patient receiving in operation theater was also a big challenge. How to manage? The patient is coming from the ICU or direct from the emergency casualty. So how we should receive the patient? Where, when, and who? Where should the patient will be received? When we have to receive the patient, and who will receive the patient? So we need a designated area and time and staff who will receive the patient. OR team should be ready prior to receive the patient. That means they should be ready with all the PPE and all the necessary items, face shield, etc., with the patient trolley ready to receive the patient. Then operation room should also be kept ready before the call for the patient, because we can't wait for the patient outside the OT or in the corridor. So we receive the patient on time. Patient should be covered properly along with the mask on the face. Patient will go straight to the designated operating room without waiting in waiting area. And cleaning and mopping of the passage with the disinfectant will be done immediately while after the patient move inside the OR. Health issues related to PPE and N-95 masks, face shield, etc. There are so many and health issues were there. As we know, there because along with the coverall in operation theater, sterile attire has to be also wear. So there is a double layer of the attire, and people face very discomfort along with that. Excessive sweating, dehydration, dizziness, muscle cramps, anorexia, even the weight loss also had. And due to continuous wearing of N95 masks, headache, breathlessness, rashes, skin rashes also found in some persons. And even due to the wearing of PPE, there was decrease in work efficiency also, because all person first no one has the experience to wear the coverall, and it restricted the movement and affect the work also. And due to inhalation of continuous carbon dioxide, there is impaired cognition also, discomfort, restricted movement, as I have told earlier. And there is a chance of fall down also, because there in operation theater minimum area was there, and we have to assist in the surgery in a confined area. So there is a chance of fall also, because lots of machineries are also used. And if you are wearing the PPE or face shield or glasses, etc., and it hampers in the visibility of the surrounding things. Then there is a impaired staff recognition. Although WHO checklist is used, but still when some surgeons are coming in between, they are not able to recognize the staff who is a scrubbed person because of all PP wearing. And spoken communication also was difficult, because mask, coverall wearing, and the voice was not clear sometimes, and not able to hear others' communication. And non-verbal communication in OT, all the time silence has been maintained. So many times we use facial expression to do the talk. That's why that also eliminated because of the PPE. Less interaction in due to the PPE, because everybody is discomfort and busy to do the work they are doing. So less interaction was there. So what we have done, we tell our staff that eat properly, hydrate yourself properly, and then only go to the OR room. And we have tried to remove all unnecessary equipment from the surroundings, like endoscopic monitors, which we are not using during the pandemic, etc. at pandemic time. So we removed monitors, machineries, so that the space will be there, and easily we can move on. And as I told, WHO checklist we enforced. Then timely takeaway of the COVID waste also is a big challenge, because they have provided 24/7 service, but due to the limited staff, it was not exactly possible. So they have set the time for the waste collection, and during one shift, one time they will come because they have to move around all of the wards and collect the waste. And so it was, and the problem was with us was that because we have to take cases one by one, and after that, where should we store the waste in? Uh, so we don't have other space. We have to keep the baggage inside the doffing room for the time being until the person will come and take away the waste. So by the time the another case will be in the queue, and limited staff was already there. One or two persons are they have designated to collect the waste from whole of the department. So how we managed, we displayed the helpline number in each OR to remind them, and as soon as the case finished, if it is possible, come and take away the waste, so we can fumigate the OT, we can arrange the OT for the next case. Then we instruct the staff to timely and routinely inform the designated sanitary personnel to collect the waste again and again, just to remind them. So because in other wards and ICU, it can be stored there, but for the operation theater, operation room, it is really difficult, because you are doing, we have to maintain the sterility also. For keeping that point, we have to instruct the staff just to remind them that they should come and collect the waste. And we advise these sanitary people to give priority to the OR room to collect the waste first, and then they can take collect waste from the other wards. Hazards related to repeated fumigation and disinfection. As we know, due to pandemic, the frequency of the fumigation, disinfection, all the things have been increases. So there is a chance of inhalation of disinfectants. Allergic reactions also was there. And due to repeated use of hand sanitizers, dry and cracked skin, many people were facing problem for that. And even the instruments and the equipments are also being rusting. Then frequent damage of the machinery is also due to the moisture. So we discussed and we made provision of fogging machines with short exposure time. That was for 15 minutes where the new machines were good, and only 15 minutes we can do the fumigation in the OR room. Then we maximum cover all the machineries during the fumigation, so that minimum damage would be happen. And we enforced our staff to wash the hands instead of using the hand sanitizer maximum time. And we advise that do oiling frequently to the instruments. One of the big challenge was death of COVID-19 patient in operating room. Usually in operation room, we don't declare death of the patient. So our staff was not familiar when the death happened in the operation theater and that patient was positive. And it create also it take too much time to finish all the formalities. So the OT was occupied for till the patient was shifted, and even there was no availability of the designated zip bags for the last offices, and that all leads to the delay in next cases. So we after experiencing this, we designed a written plan for action for care of deceased in OR operating room and instructed the staff about it, and discussed with all the staff how to manage during this type of situation. And we also try to make zip bags available in the operating room. And staff management. as we know, due to the COVID pandemic, lots of the staff in all area, they have shifted to the COVID positive area, and that leads to shortage of staff in operation theater also. And because of shortage of staff, in workload is also increases, because though the elective surgeries are not stopped for time being, but the other things have increased, like how to manage, how everyday new protocols were coming, do this, do that. So the workload for the other things was increased, and the anxiety among the staff related to their family health was also a big issue, because they were worried not about themselves, but for their family, if they will take the virus to the home and affect their family members also. So we create duty rosters with the highest rotation possible. We have seen that doctors, technical staffs, they have arranged the rotational plan for 15 days, like that. But for nurses, it was not possible, because of the due to the shortage, and the other thing, we have shifting duty, but we have to arrange that. We increase the staff in the shift time also. At the night time, lots of emergencies were coming, and so we also tried that limited staff should be exposed at one time, and we assign the assignments in such a way that no one exposed again and again to the OR room. Everybody has given different type of tubes to manage the function smoothly, and then we have done the screening for the segregated staff also. Thank you. Thank you very much.
We were not despite
Didi, thank you so much. I know how much difficult to interpret the practical sessions. It's completely practical, whatever you discussed here. So thank you so much for that. And anybody have any queries, please you can for that. Yes, sir.
As you can see here, there is a lot
I
of
have to thank Mr. Rekha. It was an excellent
Yes,
talk.
sir.
We are recording this, but you
It
can
was
still
an
see
excellent
here
talk, and
that the
I
aerosols
just
are
go
being
off
separated.
track.
And there is no way out.
Appreciate the slides that you prepared. So they were wonderful slides, and the talk was very good. And thanks for highlighting so much about the COVID and the problems that you faced in the OT. We really need to know that. And I think this was once in a lifetime experience for us, all of us.
Yes, sir. Yes, sir. Thank you.
And I will not say we are fortunate to be a part of it, because nobody wants to go through pandemics. And but yes, it was a great learning experience. And really, thanks for sharing this. And my other comment would be for Prince. His presentation was also very good. I really liked, I enjoyed the way he covered EVD. But just to add a few points, the other indication where EVD is very important is TBI patients. So that maybe I missed it, or this I must have overlooked. So EVD is very
And
important.
this negative environment
TBI
prevents the
patients
spread of the
and
virus.
posterior cerebellar stroke patients.
So this is how we created it
Patients are very
in
important.
our operation theater.
Thank you so much.
Handmade.
I hope we are running on time. So thank you, Sister Rekha, once again.
Thank you. Thank you, sir. Thank you.
It was great.
Ma'am, please share your screen.
We tried it, and during surgery also, and we realized.
Let's move on to the next speaker with the same topic, because purposefully these two topics are next to next, because of that both are challenges in management of neurosurgery. But the setting has differ. This is from the another one was from AIMS, and now this is going to be GP. So, ma'am, Venu ma'am, please you can share your views.
Good evening, everyone, and good evening, sir. I am from JIPMA. Is a new name of JIPMA. Before that is a GV Pant Hospital. I am a senior nursing officer. Myself is Beena Malhotra. And My topic is the challenges in management of neurosurgery surgery OT during the COVID-19 pandemic. Everybody knows the COVID times is very tough time for everybody. And this is the statistics of JAPMAR. And 1,109 neurosurgery cases were operated during COVID-19 period at GB Pant Hospital. Our OPD attendance in year 2020 was 4,77,328, which itself is a test the fact trust patient had a JAPMAR during COVID time. And nearly 20,000 patients who needed acute treatment were attended in emergency services. And nearly 55,000 procedures were performed on various patients in different specialties like cardiac, neuro, and gastroenterology. And over 2,500 operations were performed in various super specialty discipline. And now I'm going to introduce the COVID-19 is a pandemic in India. Is caused by the severe acute respiratory syndrome, coronavirus 2. On the 30th January, India reported, according to government index, in Kerala, the 3 students reported the positive cases from Wuhan. And first case in Delhi reported on 2nd March 2020. And India case fatality rate is among the lowest in the world at 2.41. And steadily is declining. In Delhi, almost all public sector converting the COVID hospitals and manage the surge of cases. All major hospitals cancelled the elective surgeries or OPD services. And GB Pant Hospital was designated as a non-COVID hospital. So we have attended the emergencies also. And the result was to manage both COVID and non-COVID patients. But it's a very difficult task for us and pose significant challenge to all of us. And the most pressing changes manage patient, how to managing the patient, how to protect the patient from the coronavirus, and how to protect the healthcare workers and prevent the spread of COVID further. And routine OPDs are treated as COVID positive unless tested. All staffs, residents have to wear N-95 mask and face shields and maintain social distance also. Avoid unnecessary close examinations. We have provided, and higher authorities, hospital authorities provided a glass screen separating the patients and doctors. When facilities got available, all patients coming to OPD have screen rapid test or screen for the temperature and rapid test. And we have make a separate block also for COVID patients, separate building and a separate floors designated for the different specialties. And neuro ward is a 26 and 10 bedded with ventilator bedded area. And total restriction of the patient attendant. No patient attendant inside the building. And following the standard operative procedures and protocols, after negative reports, patients were shifted to the routine wards, normal wards, another building, the known COVID building. After RT-PCR reports, not the rapid test. And positive patients shifted to immediate to the LNJP hospital from the COVID building. And because the LNJP hospital near our hospital and is a totally COVID hospital. Until now, there is no COVID related death in our institution. And we have maintained a separate ward, I already spoken to you, for suspected and positive cases. And first, we have done the screening, receiving the COVID area, any patient have come in directly in the COVID building, not in our non-COVID building. And the separate entry or exit in same COVID building, so separate entry for the patient and entry or exit, and separate entry or exit for the healthcare workers. And the separate, we have also separate elevators for healthcare workers and the patients also, non for the COVID building. And we have provided the ventilations also, because this building, I mean, COVID building have a central AC. So it's very, already Rekha told us, is a very tough task for maintain the environment for protect the COVID virus. So we have central AC, so AC people can manage 24 hours, and they give up 24-hour services also, and they put the multiple exhaust fans in different areas. And we have also maintained the OPD's area. I have shown you in slide. This is the OPD area, and make a circles for social distancing. Because of routine OPD services is going on. But in early starting especially in April and May, have a heavy rush, because total lockdown, patients have routine OPD is hang on, but higher authority told us OPDs should be going on. So crowd outside the hospital, and so difficult to manage the crowd. So we had taken help from the Delhi police. And this is the OPD, our OPD pictures, and surgeons and are there. The neuro OPD is there. Already there is a glass screen for between the doctors and patient. And the face shield they are applying, always wearing, and hand sanitization in each and every place. And area to be focused, we are reorganization of OT for us, because I'm sharing my experience in the theater. So it's a very tough task for reorganization, just like a restart the OT. And how to protect my healthcare workers from my surgeons and the technical staff, nurses, and housekeeping, and relocation of staff. It's again tough task for us, and sanitization of OT and running of OT. And reorganization of OT, changes done in theater of streamline airflow AC. The first we have the streamline airflow AC, because luckily we have a modular OT, and we have 6 OTs, 3 OTs in each floor. We have a 2-floor neurosurgery theaters. So then we are each OT have a separate AHU. So we had not faced a problem like this, maintain the AC. And this modular OTs are not central AC. Every OT have a different AHU. So we are not worry about the exhaust and something like this, like the other area we have faced the problems. And the same separate entry and exit corridors. We are making entry or exit corridors for the patient, shifting if patient is COVID positive, and in emergency we are operated. So then shifted in different corridors, not a routine normal corridors. And separate theater for positive patients. And we have separate the floor. We have 2 floors. So first floor, we have COVID positive patients, COVID OT. And DOFFING area that is the other new area we are creating. It's also difficult task. So many things are removed from there. And because of everybody is scared about the virus, and everybody is scared for the taking the infections, to minimize the things from the area. And patient transfer trolleys are also, patient trolleys totally separated, not mixed with the routine cases. And consumable shortage. I think each and every, we have suffered the consumable shortage, like mask, PP kit. After that is, everything is going on streamline, but in early stages, we had suffered too much. And provide the PP kits, and we also provide the hydrochloroquine tablets to protect the hospital healthcare workers. And relocation of manpower, healthcare care workers was transferred to other hospitals and to COVID wards. So many staffs are transferred to other hospital and hospitals, different Delhi government hospitals, and the frame from OT staff also designated to the COVID OT also. And issue related to their duties and quarantines is a tough task. We have a very feel the manpower shortage in every area, like a technical, like in nurses area, or even our surgeons have also shortage. A few surgeons are posted in the surgical COVID surgery ward, and those people are posted in the COVID area, so quarantine for the next 14 days quarantine. So that means our staff stuck 1 month stuck block, and so many staffs are COVID positives, and some staff are in contact with the COVID staff also. So we have a quarantine for 1 week, and then again RT-PCR done, a report is negative, then they again join the duties. And the same healthcare workers have, everybody suffered the transportations. Total Delhi's shutdowns. So most of the people have a problems how to come the hospital. And so higher authority arranged that transport for different, with the discuss with the Delhi Transport Authority, DTC buses provided for different area from the Delhi, and how to protect from infections, all of them, and how to isolate. So, in early stage, most of the staffs don't want to go to home. Those are posted in the COVID area. So hospital authority provide the accommodation in the hospital. We have converted the nursing home in the residential purpose. Nurses and residents stay in the nursing home. Nursing home converted in for the residential purpose, residence purpose. And the same, now the tough task for us, the OT protocols, and our role starts soon when the patient is received in the OT. So we have a checklist, or I think everybody have a checklist, but we have to check beside routine checks. It was essential to check COVID report in every case, especially RT-PCR, not a rapid test, and date when the report was done. Also inquire against symptoms of COVID. When we have received the patient, so every patient's have RT-PCR report is negative, then we are taking the patient inside the theater. RT-PCR report is waiting period is 6, only we are considered only 6 days. And every health worker has to go to the donning area to dress up before going to the OT. It is an extra heavy exercise which required initial training. Lot of time is taken in doming also. There was a responsibility to arrange sufficient PPE kit and for the healthcare workers, and special training program also provide for the all hospital staffs. In training program, how to doming and doffing, how to dispose the waste, and how to sanitize the OTs and the wards and ICU. the teaching program is also side by side is going on. And now is that again major tough task for intubation inside the theater is the next important aspect in OT. It is to have intubated without aerosol generation. For this, we are used to intubating chambers and minimize the infection. And it is the closed unit with minimum use of suction also. And now is again draping. During this period, we are maximum using disposable items, and so all type of sheets, gown, tubings, everything is user disposable items. Surgery, no, not linen. We are not providing a linen and like drills and like that. But some cases we are using also drills. And now is the same. Next step is a craniotomy for us. Is a fear of aerosol generation during craniotomy is minimized by the using specially designated head cover also, and with closed irrigation under the transparent sheet. I have shown you in next slide. So irrigation under the transparent sheet, spatially, and certain operations were deferred as high aerosol generating. And next is the extubation is again more precautions were taken to during extubation, and as per especially and patient when extubated and the cuff patient cuffs when the patient tube is taken out. And the next is the patient transferred to the table and out minimum touching to the patients. Its secretions were practiced for the transfer of the patient from table to trolley. Patient direct transfer to the ICU, not in a recovery area. Before the COVID period, we have the recovery area. Patients stay for half an hour or 1 hour in the recovery area. But in COVID period, we are not keeping the patient in recovery area. And now is the again doffing is again tough or heavy exercise, and so practice more religiously involved separations of PP kit and gloves and
Minimum 2 minutes more.
Thank you. And contained with the frequent sanitization of hand after each step, and removing the just like a PP kit and gloves and some, and were disposed as per hospital protocol. And same as OT sanitization, OT fumigation is changed every night. Have a fumigated OT, routine OT also, and COVID OT also, and the gap between two cases also. And providing a PP kit, mask, gloves, and techniques of donning and doming and disposable of kits adherent to guidelines. I already explained you. This is our donning area. It's a consultant changing room. We are converted into the donning area. We are providing the PP kit and stuff, everything, and dress up the everybody is here. This is the picture of our theater inside. So yeah, already everybody's seen nothing will be there. Is a very minimum things are there. All things and machineries are removed. And this is a picture also inside the theater. Surgeons and anesthetists have a separate type of respirator. They are purchased by own, not a hospital supply. And is the same, I already told you, we have an intubation chamber, spatial modern chambers, and intubate the all patients, either it's a routine patients or a COVID patient through this way. And this is the transparent sheet as also, and suctioning under this sheet we are using. And same is the doffing area, is the doctor's sitting room, discuss with the residents also inside the theater, convert into the doffing room. it was black garbage bags is totally removed. Only blue and yellow bags are there for the COVID or non-COVID patients. And it's the same you had seen. And this is a separate, we have a UV sterilizer. In early days, we have a mask difficult to provide everyone, the shortage of supply. So everybody is having their own mask, keep a 5 minutes here and sterilize, then next use the same mask use. And now is we have same how to select the case, so create aerosol generations. So we are avoiding aerosol generating procedures and sitting positions, TNTS and prone positions we are avoided. And we are preferred the coiling on embolization also. And this is, as I had shown you, in a separate building for COVID building, and is a separate floor. And this is a ward, COVID ward, and is a provide exhaust fan each and every place. Is 2 to 3 wards, exhaust fans provided. And the same picture is in a ward also. Social distancing we are maintaining. And this graph is a COVID time and previous year. Non-COVID years. So the red line shows the time, and the blue line is the non-COVID period. So this line has shown the time is extended. Intubation time is 60 to 80 minutes extended. When the routine procedure and the routine time and the before.
Can you hear me? Okay. When ma'am lost her internet connection, so because of that, let me conclude today's session. Today's session was wonderful, and I was not expected that smoothly it will be going, but it was gone very smoothly. First of all, I would like to thank Conference Secretary Dr. Achal Srivastava and our nursing superintendent Mrs. Ranjitkar for giving me full freedom to work with them. I also would like to thank the esteemed chairpersons, Dr. Sasimava, Dr. Seema Sachdeva, and Ms. Yangchand Dolma for their valuable judgment of the paper presentations. And also I would like to thank all the presenters, those who were presented today. I extend my gratitude to today's speakers, especially Dr. L. Kopichandran, Dr. Manju Kandavani, Dr. Hemansu Prabhagar, Mr. Bensik Prince, Ms. Rekha Pradhan, and Ms. Veena Malhotra. With our first fully digital forum, now you all safely attended the Dnacon 2021. I would like to take the time to thank every one of our friends, attendees, and partners who made today's virtual conference a truly special one. I am delighted that we have managed to move into a new dimension for sharing the quality content by virtual. I would like to say thank you particularly to event management team, and I appreciate their great work. Once again, thank you for attending our first ever virtual conference for one and all. And one more information regarding the tomorrow's conference, tomorrow's session. Tomorrow also the same time 4 to 8 p.m. and there are important topics will be covered by the very good speakers like Dr. Manjari, Mrs. Rekha Anil Kumar, Mrs. Harvinder Kaur, Dr. Savita Mahapatra, Dr. Deepika, and Mrs. Sweetie. So, and there will be the 1 hour session of common session. After that, the session will be started by Mrs. Sivu Riju, Dr. Rajiv Agarwal, and Dr. Seema Sachdeva. Hope that tomorrow also the conference will be going very smoothly. Once again, thank you all for your wonderful cooperation and guidance and support. Thank you.
Thank you, Anjali. Thank you.
Thank you.